So without further ado, let me introduce our first keynote speaker of the day, kicking off really the people part of the summit. James, Lord Bethell of Romford, Parliamentary Under Secretary of State at the Department of Health and Social Care. Lord Bethell will be talking about the role of digital technology in the response to COVID-19 and how we can use the learnings from the past year to move forward. That's been a big topic of discussion. How can we learn from all the things that have happened, all the things we've done? And I should also mention that our Health and Social Care team published a 10-point plan for health tech, drawn from member contributions and interaction with various NHS colleagues. And it sets out 10 recommendations to strengthen the UK's reputation for health tech, which is very good, but also to look at how we improve outcomes for citizens. And we've got some challenges there, I think, in the general health of our population. But we've got some opportunities to do something about it. So please take a look at that. It's available on our websites, and we'll put a link in the chat. Lord Bethell, it's a pleasure to have you with us this morning. And thank you very much for joining us. And if you're ready, I'll hand over to you for our first keynote.
Thank you very, very much indeed. And I've known Tech UK for a very long time. Hugely support and admire your work. And I'm very, very grateful for this opportunity to open this important discussion. Can I just start by saying a huge thanks to everyone in the tech community. Tech, in the broader sense of the word, has made a huge impact on our battle against the disease, but not actually in some of the ways that maybe we thought at the beginning it might do, but in ways that are possibly more profound and will leave a longer legacy on our healthcare system. And I want to talk about that legacy, and I want to address your 10-point plan for health tech, which I think is a really valuable contribution. And I'd like to see you push hard on it and to keep scoring us on our progress against it. The most vivid and the most emblematic example of where medtech has made a difference is the huge shift from GP face-to-face attendance to video attendance. I mean, that is the emblem, the symbol of tech and the epidemic. And it's in itself, were that to be the only thing, been a huge change. GP surgeries are a source of great infection. Not only did the public not want to go to GP surgeries, GPs didn't want to go to their surgeries. And so a lot of them were either closed or massively scaled down. And yet, thank goodness, we had invested in NHS 111. We had many GP surgeries had already put in place video conferencing facilities. And if they hadn't, groups like NHSX did an amazing job of firing up the capability. And now every single GP surgery has that capability. I've got 4 small, horrible children who are always ill, and I cannot imagine going like I used to and sitting with loads of snotty children in a GP surgery at 8:30 in the morning in order to infect each other. It just wouldn't happen again, and I can't see that going back. So roughly 50% of appointments are now done over the video. The question is, are we going to fall back to the old way, stay the same, or make progress and increase? You know, it wouldn't surprise me if that number went up and edged up further and further. And GPs themselves, many of whom have commitments at home, I think profoundly like that arrangement. But that is not actually where I have seen, and if I can just speak personally as the innovation minister who has been on the front line of the sort of departmental response to COVID, I want to just single out 5 areas where tech has made a big difference. And this is not a theoretical framework. This is a personal experience sharing. So the first is just the sheer quantity of data. I mean, the colossal number of files that are generated by the epidemic. One day someone will calculate this, but if you look across the really big initiatives, clinical trials, test and trace, the vaccine rollout, and more recently, test to release, hotel quarantine, and long COVID. Those are the 6 projects that I have been closely involved in. Test to trace, with including the community testing in schools and in workplace, it's now generating 1, 2, 3 million patient records a day. I mean, we're in lockdown at the moment, so the use of lateral flow devices is limited. But when we hopefully open up, this is a massive increase in the sheer number of data, quantity of data. And the processing power involved has been absolutely huge, and I think represents a huge opportunity. But I would like to thank enormously all those in healthcare, in tech and in data who have done so much to colossally scale the capability of the system. Secondly, in terms of sharing data, boy, oh boy, we've broken some boundaries. We put through the COPI notice at the very beginning, which I think all the feedback we get is that that was a really great moment, which gave people permission to use their professional judgment and share data in a way that helped them achieve their health objectives and supported the savior of life and avoidance of disease. And data sharing has, I think, matured dramatically in the last 10 months. Now, it's being done within very strict tramlines of privacy and cyber security. No one's blowing the lid, no one's tearing up the rule book. But gone are the days where primary care or trusts or the centre are in pitch battle or suing each other over the sharing of essential data, which is frankly how we used to conduct business in the bad old days. And that is a huge, huge relief. And I think an area where we have made huge progress, and I really, really want to build on that. I had a very vivid example of that during the passage of the Medicines and Medical Devices Bill, where patient groups representing those who've been affected by vaginal mesh told unbelievable, but heart-rending stories of how they had reported incidents for years from one end of the country to another. But it simply wasn't legal for the MHRA to take a file from one patient in one area and match it with a file from another patient from another area. Julian, worry not, we can still hear you. I'm going to continue, even though we appear to have lost our host. That has had a massive impact on patient safety and on the ability of the system.
I'm still here, James, don't worry. It was someone else.
To track these awful diseases. That cannot ever happen again. And I think we have definitely moved on. Thirdly is the very tricky area of identity validation, knowing who you are. Now, the origins of this in the epidemic were our battles over Apple, the Apple COVID app. And we found a route through and embraced the Apple protocols that do not, in fact, share any identity verification. But since then, we've actually come a long way. And I have become increasingly convinced that it is simply irresponsible and dangerous for the NHS or for any public health official to conduct a test or any health interaction with someone who they don't know who that person is. And that principle, which is rooted in patient safety, but also grounded in common sense, has got to be our watchword. And I think we have made a lot of progress on that. And I think that one of the most important things is that patients themselves realize that it is important that they are able to identify themselves to those with whom they're interacting. Fourthly, it is in terms of usability. Now, this has not always worked well. We have bought stuff that when we've put into the front line, people have rejected and it's been sent back in its box. We have had stuff that has had a lot of promise but hasn't really worked well. But the rate of iteration on usability, I think, has improved dramatically. And things that didn't work at first, I think, have got better. And to give a really good example there, we've deployed a huge army of people who are doing testing in the little funny tents and in shopping malls and drive-through centres up and down the country. The initial web-based data system that they used was incredibly clunky and complained about a lot. it is now seamless. And in fact, we can hand the iPhone to the testing party themselves, and they can fill it in themselves, as I do twice a week when I go and get my test. And then lastly, in terms of analytics, the work of the JBC, the Joint Biosecurity Centre, has pulled together a vast amount of data from our COVID response and applies amazing algorithms and data analytics and presents it in a beautiful, easily accessible way now, in a way that I don't think we were doing a year ago. And that is really, I mean, certainly as a policymaker and someone at the receiving end of that insight, I have seen a huge, huge increase. So those are the 5 ways that, as a minister, I have seen tech and in particularly data used in the deployment of our battle against COVID. There have been some low points. The words CSV file are ones that send shivers down my spine, particularly after the great and famous CSV file fiasco. The word workaround also sends shivers around my spine. And whenever someone says, we found a workaround, I can pretty much set my clock that the whole thing's going to explode in a month's time. And the word stand up also worries me because it implies using legacy COBOL-based antique tech in order to solve a 21st century pandemic response issue. But the thing that I really, really want to emphasize, and where I think we have got to, and we are definitely making progress on, is that out of the billions of pounds that we're spending in terms of pandemic tech response, there is a much greater sense of mission about creating a legacy for going forwards. Because not only is the very large amount of money that we're spending got to have a return on investment, we have got used to the idea that pandemic response is something that's going to be a generational challenge, not a one-off event. And people are interested, and it's human nature, and people are stepping up to the challenge of figuring out how we can build back better. And that phrase has, I think, got real resonance. And if there's one thing I want to try and leave an impression of, is the challenge to tech of how to not just apply the sticking plaster to the current problem, but to really think through about where you're going to get to. And in that respect, I really want to get across the idea of the big generational challenge we have as a healthcare system of moving from late stage acute intervention to early stage preventative medicine. And tech is absolutely critical with that, because late stage acute medicine is largely and solved by a face-to-face meeting where you present some colossal symptom, some great big growth in your body, and ask the healthcare system to dig it out and save your life. Whereas preventative medicine is by its nature more subtle, more thoughtful, more to do with risk assessment, more to do with diagnosis, more to do with behavioral change. And those are the kinds of challenges where tech is very well suited to presenting solutions. And in particular, in that area of behavioral change, we want to give our patients the data, the information, and the motivation to take health into their own hands and to change the way they live in order to suit their own health challenges. So I want to say a massive thank you to the tech community for the kick-ass ninja action culture of the community, which is well known, but should always be credited for. And also the quality of the work, some of which has been absolutely staggering. And there have been several instances where I have been completely blown away by the achievements of those I'm working with. In terms of your 10-point plan, I'm not going to address every point, but let me just say a few words about it, because I think it is very much in the right direction. And I would like to, I hope it won't be a piece of vaporware. I hope it's something that we will look back on in a year's time and score our homework. In terms of putting the power into the hands of the public, I think that there has been a lot of progress on that. The really big image is of iPads being sent to those who have got COVID. We don't want people with mild symptoms of COVID to come to hospital, to clog up beds, to get other infections and to be a distraction. it may well be that they get through their disease without any major medical intervention at all. But as we know, some people, particularly if they have comorbidities, can descend very, very quickly indeed from being okay to severely ill. And therefore, giving someone an iPad and an oxygen meter for their finger and the ability to supervise their symptoms remotely from home is hugely important. Now, that would normally be done in a way that is simply not quick enough or accurate enough or responsive enough to really deal with the situation. But tech has presented really great technology that means that we can confidently keep an eye on thousands of patients, keeping them at home, sparing them a hospital visit and leaving the beds free. And that is a really graphic example of how tech can put power into the hands of the public. We've also sent thousands of iPads to social care so that people in their homes who can't make face-to-face visits because of hygiene management reasons can Zoom their relations. That provides a hugely valuable and motivating connection between those in social care and their families. And that's a slightly lower tech, but really important example of that. We need more of those examples. In terms of a world-class digital health and care standards, we've made this one of the high priority items on our chairmanship of the G7 health, the G7 overall, and particularly the health track. And we had we have four elements: pandemic response, AMR, clinical trials, and data standards. Now, data standards sounds like the most prosaic and wouldn't normally, frankly, get above the salt line at a G7 dinner. But the response at ministerial meetings last Friday was incredibly strong. Everyone agreed that that was something that they wanted to work on together. In terms of communicating the value of digital health, I think there's more to do. I think you as an industry do need to make it relevant, not only to hard-pressed frontline healthcare workers, but to patients themselves, to figure out how the combination of tech and data can provide transformative impacts, not only on those who are trying to define their own personal healthcare, but also those who are trying to apply it. I think we are getting there. Lord Aradazai is a great champion for this sector, and I'm looking to him to do more. We have put medtech firmly on the legislative footing with the Medicines and Medical Devices Bill. NICE focusing much more on medtech. I think they acknowledge they haven't done enough in the past. I am personally very keen on medtech. It's where I instinctively have a connection, and I'm very pleased to be a champion. But I do think this is an area that where we need to do more. In terms of centrally mandating, assessing, and enforcing the use of interoperable standards, boy, oh boy, there's more to be done here. Now, I pay tribute to the work of NHSX in particular, and to Matthew Gould and to Simon Madden and the fantastic team we've done there. They have done a huge amount. And NHS Digital are doing a huge amount. But there is far, far too much siloed data buried in the basement on cobalt machines with a long, long legacy that no one can ever get a hold of. It may as well be in queue in dusty folders for the use it's in. We need much greater standardization, use of APIs, the use of platforms, so that data can flow more smoothly. And the Secretary of State, who, as most of you probably know, his family background is in this kind of area, is very, very hot on this. In the Medicines and Medical Devices Bill, we have legislated for a medical devices information system to bring together all the different databases from every Royal College, every database put together on the fly years and years ago that's sitting dusty and inaccessible, in order to make progress on that. And I think that that is one useful step. In terms of supporting integration of social care through digital transformation, this is a big priority for NHSX. It's a massive challenge. I mean, we have some fantastic social care groups who have embraced technology, but we have a lot of mum and pop shops with half a dozen residents who don't have broadband, let alone a computer. And so there's much more to be done. In terms of enshrining the role of integrated care systems into law, You may well have seen the leaked copy of the NHS bill that was kindly put on the internet on Thursday. Thank you very much to whoever thought that that was a good idea. And we hope to be announcing that more formally very shortly indeed. And then lastly, in terms of the streamlining of the procurement of digital technology, there we pursue a twin track. NHS X is doing a huge amount to try and increase skills in data in technology procurement, which is really important. But we also want to liberate people to try and experiment them. We don't want a cookie cutter approach. My colleague Ed Argar, who is overseeing the very large hospital refurbishment program where we're building or rebuilding 40 hospitals, has got tech at the center of that infrastructure plan. It isn't all going to be bricks and mortar. It is also going to be bits and bytes. So thank you very much indeed for that. I think one area that you haven't touched on, but I am acutely conscious of, is that whilst we have spent a lot of money on tech and we have made a lot of progress in some of the what I call architectural elements, we haven't created a new ecology of small startups and kick-ass, challenging, disruptive tech companies. I pay tribute to those who are already in the market, but the market could be bigger, it could be more empowered, it could have better access to the data platforms of the NHS. We could, as a government and as a system, be doing more to have a startup Britain approach to medical technology. I did a Zoom call with the Israelis yesterday. I mean, it just blows you away. They're so aggressive and so ambitious and cover the ground so quickly. We do need a little bit more of Tel Aviv in Tech City, UK. That is something that I am really conscious of. I know Matthew Gould is also conscious of, and I would very much welcome your advice on how we can do that. So Julian, I've slightly run over. I hope you'll forgive me, but I just thought I would share that slightly personal account of how we've been doing during the epidemic. Thank you very much.
Thank you, Minister. I think no problems with time, and I think we all now want a follow-up conversation with you because you raised so many very significant points there, and I think you were very frank about what we've done well, what challenges we face, and things we're learning from those challenges. I think that is a new attitude, and I think that will help immensely. As we look into the future, one of the most encouraging things that we've found right across government, I have to say, is much more openness, much more partnership, much more let's give it a go and try things. I know how difficult it is for officials and ministers because there is a whole bunch of people wanting to find the failures and discounting the successes. But I do think that we need to be brave and bold, both of us. On our side, I think we understood the challenges you just put our way. And I think we take that very, very seriously. And I think one of the other things we haven't done in the past, as well as the new entrants, new companies, smaller players, bringing new ideas, we haven't brought the best of our established players into the NHS in the past either. One way or another, all the innovation and the things that are happening in other countries often is done in conjunction with the very companies that are stuck in or have been stuck in the past in the old way of doing business for government. So the crisis has given us a real shake-up, and I think you've outlined an awful lot of that. I'm taking data away. I'm taking challenges on speed of innovation. I'm taking away the idea of this cooperation, and we've seen, the NHS and the ministers involved with the NHS very determined to bring innovation to play. So we wrote that plan. We do intend it to be something we keep to and measure and work with, and we wrote it with colleagues in the NHS and in government. So that's great, and it's really good to have a chat with you, and we look forward to more of that. I know I've got to hand over now to Anthony, who's going to lead a panel now looking at some of these aspects and maybe even some broader stuff about what's happened and how it's affected speakers. But let me thank you once again, Minister, for joining us. Really do appreciate that and appreciate your frankness and the challenge you've given us. Let's get on with it.